Okay guys, we're going to talk a little bit about nasopharyngeal suctioning, oropharyngeal suctioning, and very briefly about tracheal suctioning. Okay, so the reason we suction is when somebody is congested. They have mucus coming up from their lungs or through their throat. Sometimes it can be blood, sometimes it's mucus, just depending on what's going on with the patient's condition. And if you have already looked through the PowerPoint, you've seen that sometimes patients just need suctioning to clear their airway. So if someone has an occluded airway because of secretions, blood, infection, masses, whatever, one of our primary nursing diagnoses would be potentially ineffective airway clearance, followed by impaired gas exchange because we're not getting air there. Okay, so what I'm going to show you first is some of the tools for nasopharyngeal and oropharyngeal suctioning. So first here you have what's called a yonker. Okay, mainly that's for oro. We have used it for nasal suctioning sometimes whenever we're in a pinch. Here we have a suction catheter, which could be used for nasopharyngeal suction. Most suction catheters are around 14 French. This particular one's 12 French, and it is a sterile, comes in a sterile package. If it's a nasopharyngeal suctioning we're doing, it is not a sterile procedure. If it's nasotracheal suctioning, it is a sterile procedure. So this is the catheter. Okay. All right. Next, what I'm going to show you is a sputum trap, because sometimes when we're suctioning, we may want to get some of the sputum to go to lab. This is considered sterile. That way, if we're suctioning the trachea, we're suctioning oropharyngeal, we need secretions. Okay, secretions come in here, and I'm going to show you how to hook all this up here in just a minute. But that is called a sputum trap. Okay. Alright, so over here on the wall is your suction setup. Okay. Alright, when you're looking at suction, you got to look at how high the vacuum is as far as what we turn it to. This particular vacuum, we can turn it here where we can, you see the needle move, and you can adjust it. Okay. Or if we're in a trauma situation and we want to have full suction immediately, we just turn it to line, and you can probably even hear it. Okay. So this is the suction on the wall. Okay, you can probably hear it suctioning through there. Alright. Here we have the suction canister. Okay. This canister is here so that secretions that we suction do not go straight from the patient into the actual wall suction, because that would mess up the system. So we got to have a mechanism for us to capture whatever it is we're suctioning, whether it be mucus, whether it be stomach contents, regardless of what it is. Okay? So the way that this is connected, there's always a short piece that connects to the bottom of your suction regulator. Okay? The regulator pushes into the wall. On the top here of most suction canisters, right here on the top, sometimes you can see that it's diagrammed. It's probably going to be hard for you to tell here on the video, but here on the top is where the vacuum is actually plugged in. So the wall is to here, okay, and then our suction runs through the actual canister. Okay, then our suction tubing, okay, the long tubing gets connected to the appropriate port, which goes to the patient, and it actually reads beside it, patient. Okay, so the next thing I do is when I come to my patient, and if I'm going to perform oropharyngeal suctioning, grab my yonker, and it goes right here. Pushes on tight. Turn my suction on. For a yonker, you really need to have it on full suction. because this will be a patient that can get his secretions up to the back of his mouth, but maybe can't spit it all the way out, or maybe has so many secretions he can't keep up with it. So just like at the dentist office, kind of put it to the side of the mouth. If somebody's really struggling and we know that they're trying to cough and they're getting that pneumonia, that secretions, the pus, and the secretions up to the back of their throat, but they can't get it out, we have been known to go beyond the gag reflex and not go in the trachea, but way back in, clearing that oropharyngeal passageway out. So that's oropharyngeal suctioning. We can sometimes use this for nasal suction if we have a lot of bleeding and it's occluding our airway, okay, or mucus, for whatever reason. Try not to go from here to here, okay, here to here. We can suction. Preferably it's just oropharyngeal. You can find a blue towel. What I like to do with mine, to use it over and over, put it in a wrapped blue towel or a Chucks and stick it under the pillow so it stays there, and then you turn the suction off. Okay, that way it stays somewhat clean and it stays within the patient's range. The great thing about the Yonker is if a person knows they're having difficulty coughing secretions up, they can keep that. They can hold it and they can put it in their own mouth. Okay, so patients can use the Yonker by themselves. So that is mainly oropharyngeal suctioning. Okay. We generally don't get a sputum collection with oropharyngeal suctioning. Next one I'm going to show you is nasopharyngeal. Nasotracheal suction will happen next semester. But just like the Yonker, this connects here. This right here is called a chimney valve. Okay. This is considered sterile until you touch it with clean gloves, and I would have gloves on here. Okay. And the way that this works, let's say that there's secretions in the back of the throat coming through the nose, and we want to clear out the nasal passage as well. Again, we turn it on line suction. We keep our thumb close to the chimney valve here. We sometimes lubricate. We never suction while we're going in. The way that we create the suction is to put our thumb over the chimney valve. So if the air's coming in through here, when I put my finger here, now I've got suction here, and you can hear that. Okay? So we lubricate, never suction while we're going in, go to where the patient will kind of start gagging. Once they gag, you know you're in the pharyngeal space. Start suctioning and rotate the catheter back and forth. Okay. Give the patient plenty of time to take deep breaths. Okay. If they can, go to the other nair. In. They start gagging. Start suctioning that out. Okay. Alright. And sometimes you need to follow that up with the Yonker if they've started coughing or gagging. Maybe we're suctioning vomitus, whatever it is, we're suctioning all that out. And it's sometimes easier to have the patient close their lips around it, and it creates a vacuum in their mouth and it suctions all the secretions, just like at the dentist office. Okay. That was nasopharyngeal. I'm going to show you nasotracheal. Okay. Now I've got sterile gloves on. We'll pretend because this is a sterile procedure. Now my left hand is no longer considered sterile because I'm touching the patient's, the suction side of the tube. So this goes to the wall and this will be attached to them. But all this is sterile. So I want to make sure I maintain sterility with my sterile glove on. Okay. I would have some sterile saline here. Have the patient take 3 or 4 deep breaths so that it can hyperoxygenate them so that they don't vasovagal. Or create a low heart rate. Okay, so we lubricate with the saline, lubricate, and the difference is when we nasotracheal suction, we keep going past the gag reflex. We would have the patient sitting up a little bit higher, head tilted back so it can go into the airway, and generally it goes all the way to the chimney valve. Then we start the suction and rotating. That gets secretions out of the trachea. Let the patient get their breath, put oxygen back over them, and there's going to be secretions in the tube, so you want to dip it back into the saline, suction and saline out to clear the tube. Then we go to the other side, again all the way down. This is nasotracheal. Maybe they start coughing because you hit the carina, so we start suctioning and rotate. Okay. Very rarely do we do orotracheal suctioning like this, but it has been done depending on what the patient's condition is. Okay. And then you'll learn what tracheal suctioning is when they actually have a trach tube, and again we're sterile, and you go into the trachea and it will go through the tube, and then they'll cough with about that much of the tube in because it will touch the carina. Then you suction out. Okay. Now, if we wanted to gather a sputum collection, and mainly from nasotracheal suction, but I want you to see what a sputum track is. The way this works, okay, suction goes here to the side. Now I have suction here. Put my chimney valve there. Okay. And now basically what I've done is created a reservoir where I can go in and suction. Nasotracheal, I'm sterile. When I put my finger over the chimney valve, whatever I'm suctioning out comes in here. Okay, try not to keep it too far turned upside down. And it just collects the sputum into here. Alright. And that is, when we get done, take this out, throw it away. Generally put that right on top there, like so. Label it just like you just did in specimen collection checkoff. Turn it off. Okay, label it, patient's name, their label that would come off of the chart, your initials, and what the sputum or what the culture is, that it's sputum. Okay, so that is oropharyngeal suctioning, that is nasopharyngeal and nasotracheal, and indications for suction. Sometimes you have to watch out. If you are doing a lot of nasopharyngeal and you keep going into the same spot, it can cause a track, and it's known as tracking, and it will irritate, and it will start bleeding. So the way that you prevent that is lubricate well, and make sure when you're suctioning, you suction the way out, twisting that. Okay. If you see a patient's heart rate go down while you're suctioning, you want to stop suctioning, let the patient hyperoxygenate by taking some deep breaths, and then you can go back and suction should you need to. Okay. And that's all I need to show you on nasotracheal suctioning. I'm sorry, nasopharyngeal suctioning.